This
tonight?
conference will now be recorded.
Hello, yes. Hi, Herb. Nice to hear your news.
Jimmy, would you like some time tonight?
No, thank you.
Good. That's good to hear. That means everything's staying in place.
Yeah, I'm dry, man. Nothing to say. It's dry. That's all.
Sylvester, would you like some time tonight?
No, thank you. I'm happy.
Well, happiness is always important. That's really good. Len, would you like some time tonight?
Well, like last week, put me at the end here. What I have is only a
Okay.
time filler.
All right. Frank, would you like some time tonight? Frank Fabish?
Yes, please.
Okay, you got it. And John Ivory, how are you doing?
Nothing for me tonight. Thanks, sir.
Okay. And we now have somebody named Tad who just signed in. He's coming in on the telephone. And I'll wait for him before we start sort of our official meeting. Well, it's 8:06, so we still have a bit of time till the official 10-minute interval.
Herb, you missed me.
Yes.
Herb, did you get Jimmy Campbell? He just arrived, I believe. He's new.
I know, that's what I'm and Tad. Oh, we have Tad just arrived.
Yeah,
Tad,
I haven't been. It's been like a
Tad,
year.
is this your first? It's been a year. Okay, well, would you like some time tonight?
Actually, yeah.
Okay, it's been a year. Gary Peters, would you like some time tonight?
Thanks, Herb. No, thanks.
Okay, gotcha. And Tad, would you like to introduce yourself? You said it's been a year. Fine, so we will get to you. But all right, I think even we have a bunch of people, and we're recording, so I think we can start. I guess we'd like to welcome Vincent Wilmot with us, and and for those of you that weren't here, Carol is on another line, so they are connected, even though they're on two different lines. So we have a little routine. We have a little routine here where we ask a bunch of questions just to get some information from you to give us a basis on which to start a discussion. So it's a little formalized, but it will help all of us get moving. So first of all, how old are you? I'm sorry, I missed it.
61.
61, okay. And where do you live?
Gaithersburg, Maryland.
Oh my. We really are taking over this group, aren't we?
Come again. Here they come.
Are most of you from Maryland? Is mostly everyone from Maryland?
There's a lot of us on this call from the DMV.
Florida.
So tell us when you were first diagnosed.
So I was first diagnosed in 2015. And in February of 2016, I had open surgery and had my prostate removed. And while my PSA went to 0, I had 0 urinary control after that. So in 2018, I got an artificial urinary sphincter.
Okay, well, we have you and Jimmy share something in common. I think this area seems to like urinary sphincters, don't we?
Well, it's better than not having.
Where are your doctors?
So I had both of these at Johns Hopkins in Baltimore.
Mm-hmm.
And
Okay.
my PSA was 0 for the first 4.5 years. And a couple of months ago, I went for my PSA and it was 0.2. And I called my urologist and he sent me to the oncologist and they ordered another PSA and it was 0.2 again. And then they ordered another PSA and it was 0.3.
And how late? And that was after how long?
3 weeks maybe.
Uh-huh.
So they sent me to a radiation oncologist who sent me to another radiation oncologist. And they're recommending this salvage radiation, 8 weeks of treatments, but I'm still gathering information. And they told me that before I did this, they wanted me to get a PET scan and an MRI. And the MRI is for this weekend.
Mm-hmm.
And the PET scan seems like it's been an argument between my insurance company and and the doctor's office as to whether I can get a PET scan.
Huh. Do you know what kind of a PET scan?
Do I know what kind of a PET scan?
Right. I mean, PET is positron emission tomography, and there are different tracers that they use. Do you know if they said they wanted a PSMA PET scan or 18F PET scan?
We don't know.
I don't know.
Okay. And this is all being done at This is all done at Hopkins.
So I'm going to Hopkins affiliated facilities, and there's several of them here in the
You're going
area.
to Sibley or something?
So yeah, the PET scan was scheduled at Sibley, but it's supposed to be on Thursday, but my insurance to this point has not approved this, and from what I understand, this is a very expensive exam. So I'm trying to get the radiological oncologist to talk to the insurance company to figure out if I should get this or not. And his argument is that after my prostate was removed, my Gleason score was 9.
4 plus 6.
Okay.
And
was that 5 plus 4 or 4 plus 5?
4 plus 5. And, he was saying that was a relatively aggressive cancer and that perhaps I should try to get the PET scan as a portion of the diagnosis that they're doing. And to this point, the insurance company has not agreed.
Because PSA is,
because my PSA is.
I mean, I think that's something that this group would also have noticed. That in fact, these scans are generally not that reliable with the PSA value that you're giving.
Right.
So all right. So now but the MRI for sure they will be able to do.
Yeah, the MRI is scheduled for Saturday, and that doesn't seem like that's an issue, though I haven't spoken to the MRI center to confirm that I'm approved, but...
No, you are. They've approved that.
So the MRI is approved, Carol says. But the PET is not.
So now I definitely get a sense of where you are, and I guess the question I would ask next is, do you have some questions for us that you would like us to discuss?
Well, so, I'm still trying to gather information, and one of the reasons that I got a prostatectomy versus getting radiation initially was concern about damage to the surrounding organs from radiation. And now when I'm faced with this additional decision as to whether to get this salvage treatment, I'm concerned about whether getting the treatment or not is a better course of action for me. So, I don't evaluate things.
I guess one question I would ask when given this lack of approval from your insurance, of for the scan, was there any discussion with your oncologist about waiting a little bit until the PSA went up so you could get reliable results?
So he hasn't really said that, and he has said that usually at the level of PSA that I have, these diagnostic tests don't really come back with a whole lot.
But he did say, though, that the longer you wait, right now if he's recommending not only radiation but hormone therapy for Vince.
Okay.
And the
Has he
combination
had any hormone? Have you had hormone therapy before, or would this
No,
be the first time?
this would be my first one.
But the combination of the radiation and the hormone therapy, he's saying it's 6 months, a 6 month treatment of hormone therapy is supposed to give them combined, chances of, anywhere between 70 and 75 and 80 something percent. Um, um, of, you add 10 to 15% for the hormone up to the 60-70% range on just radiation. So, you get about 75 to 85% chance of, it not recurring.
Well,
He says that the longer we hold off, the success rate of this goes down. And that, it is typical for, when you start seeing a 0.1, or one radiologist told us we tend to do radiology treatment even at a 0.1. The higher it goes, the less likely it will work. So that's why he's recommending that we go ahead and do it now.
mm-hmm.
And we just wanted to get some viewpoints on that.
So has anybody here had salvage radiation after
Yeah.
RP?
Yes.
Yeah, so let me just say a couple of things first, Herb.
Okay.
I have some concern about some of the advice that you're getting. For me, it wouldn't work. That said, the first thing is I think they're probably right, the insurance company, about not doing the scans just yet, because they're not going to show a heck of a lot, the PET scans.
Right.
Really need to wait until, depending on the scan, somewhere between 0.65 and 0.85 to get a reliable result. Now, that said, if I had had a prostate that had a Gleason score of 4+5 and the disease came back, there are probably two steps I would take. One would certainly be to get radiation, even though I hear what you're saying about you wanting to avoid the damage of the radiation. I think that your prostate bed probably demands radiation. We can't give medical advice, but if it was me, I know I'd want that. And
Right.
I'd also want my whole pelvic girdle radiated. And this is another area where we often find that the doctors will only radiate the prostate bed and not the pelvic girdle. When I was diagnosed, I had the pelvic girdle radiated with a Gleason 8, and I'm frankly very glad I did. Was it without side effects? No, but I think it was the right decision. The second thing I would strongly recommend, well, I can't say I would recommend because I can't give you medical advice, but what I would do, and I did do, is more than 6 months hormone therapy, because with the Gleason 4+5, that demands more. And it's hard for me to fathom how if it was a Hopkins radiation oncologist is saying only 6 months, because the protocol for salvage radiation with 4+5 is somewhere between 18 and 30 months, depending. That really depends on the radiation oncologist, but we wouldn't expect less than 18 months. So I'd be drilling down on why they're only talking about 6 months. So that's my 2 cents.
So 18 months of hormone?
Minimum.
So can I make a quick comment? If your PSA went from 0.2 to 0.3 in a matter of weeks, I suspect you'll get up in a range that's where a PSMA scan would work. And if you were to get in the line up wherever the PSMA scans are being given on trial or whatever in that area, by the time your name came up, it would work fine.
Mm-hmm.
So the insurance company might go for that. I don't know.
Yeah. Maybe that's the other thing is if we take another PSA and it shows another increase, then maybe they will be convinced that we need to get it done. I'm really concerned. The doctor, the radiation, do you mind me sharing the doctor's name, Vince?
I don't care.
Yeah.
Please share.
It's Dr. Greco. Have you heard of him? Steve Greco?
Yes, this is Ravi. That is my oncologist too at Hopkins.
Yeah. He's the one who's giving us the advice.
Well, I would just drill down with him and say, why are you only saying 6 months? I'm a Gleason 4+5. And just ask him directly. If he has good reason for it, if he can show you the evidence, but what I can tell you is that most of the studies that have been done, the clinical studies, would suggest longer than 6 months for a Gleason 4+5. But if he has good reason for it, then by all means.
I also asked, with a Gleason 4+5, why didn't they, in other forms of cancer, they not only remove the actual cancer organ, but they also do a little either a little chemo or maybe a little radiation that further, reduce the risk.
4 doctors have said no to that already.
And I know, and so my point here is I think maybe the reason, and I asked them why they didn't do it, and they said, well, because it was contained within the prostate cavity, that it never seeped out, and therefore that's why they did not recommend doing anything further. And the reason I'm bringing all of this up is maybe that's why. I don't know, but could that possibly be why he's only recommending 6 months?
I mean, I don't think one thing
It's
has
hard
anything
to say.
to do with the other. I don't.
Okay.
Go ahead.
It's hard. I mean, I think let me ask other guys because I'm not sure. Do you think it's time to get a medical oncologist involved?
It's always tricky when you're at a multidisciplinary center, Herb. But there's no reason why not. And I mean, you could get a second opinion. You're not a second opinion. You could ask for a consult with
Antonarakis.
Either Denmeade or Antonarakis, I would suggest, and just ask them what their view is on how long you should be doing hormone therapy. I mean, I think the issue here, to be honest, is one of not what treatment to do, because probably everyone's on the same. Well, I wouldn't even say that. Did Greco tell you what he wanted to radiate, what the radiation field was?
I think he just said everywhere around the prostate bed area.
Right.
And I don't recall the pelvic discussion, but
this is a problem because there are many very good radiation oncologists who do not radiate the prostate girdle. I just came across a situation with one of our guys at OHSU, Oregon Health and Science, which is a very fine institution. But certainly most academic and a lot of private practice radiation oncologists will radiate the pelvic girdle. We think it gets better results. I personally think it gets better results because that's what I did. And it becomes an argument, and you have to push. if it was me, I definitely would want the whole pelvic girdle radiating. Because basically that takes in all the pelvic lymph nodes rather than just the ones that were immediately close.
But I guess, let me ask you, Rick, I don't know that I would do it without getting a scan first.
I would disagree. I think that the practice has shown that it is a better way to go, whether or not, because you can't always see, you can't see because of the micrometastasis. So so if you were, you know, and the biggest proponent of this is Mac Roach.
Okay.
And always has been, and it is controversial, but I don't know. I throw it over to some of the other guys, but what we see all too often is the guys that just get the pelvic bed radiated in terms of adjuvant or salvage. It doesn't work. They come back and they need more radiation.
Can I ask you to back up just a second? There were two names that you suggested in terms of medical oncologists. What were their names again?
One is why don't we put them in the chat window? Does everybody
put them
know
in the chat window?
Does everybody know how to use the chat window? It's the little speech bubble in the
upper right hand corner.
Upper right hand corner, and just open it, and momentarily you'll see the two names.
Okay.
And you can look them up on the Hopkins side.
I just put them in there, Rick.
Thank you.
Okay, so I mean, I guess, I think, are there any other comments you'd like to make about this? Because I think we feel like you need more therapy, and I think certainly, you know, you would hear from Rick and from your radiator oncologist that that's appropriate. I think most of us would say with a Gleason 9, yes, it's time. You could also do ADT, but I'm not sure I would just do it for a short period of time.
Has Vincent ever had a CT scan and a bone scan?
Well,
no, I'm having an MRI on Saturday, and we were trying to have one of these PET scan things, but the insurance company does not feel that
You might want to try a CT scan and a bone scan, which is just standard procedure for anyone with a Gleason 9. If you've never had it before, I'm sure you'd qualify.
Okay, so a CT, so instead of an MRI and PET scan, consider
No. You need the MRI and PET scan.
Okay. The MRI.
CT and bone scan are much easier to get approval for because they're pretty much standard procedure, just to make sure that there's no spread beyond the prostate bed. There's nothing going on in the bone, something.
Part of the issue is that my PSA was undetectable for close to 5 years.
Right.
So, you know, this is a new onset, and I guess I'm having some, you know, I don't know if this is going to aggressively go up or this is a one-time thing, or, you know, if I'm
right. But I think
2 years from now.
I think you need to watch it, and I think you need to get some scans, and you need to get some therapy. There's no question about all of that.
Yeah.
Yeah, Vincent, I would say you have been incredibly lucky to have a Gleason 9 and just have a prostatectomy with no other treatment and be undetectable for the following 4 or 5 years. You're like 1 in 1,000. Gleason 9 is very aggressive, and you just consider yourself very lucky. And like Rick mentioned, probably a good chance that there are micrometastases. Definitely get a second opinion about radiating the pelvic girdle in addition to just the prostate bed.
Okay. And we'll confirm.
If I could,
we'll confirm with him as well in terms of where he's
so I
playing.
think, unfortunately, I think we have several other new people.
Yes.
Tonight,
Thank you.
Thank you so much. I don't want to dominate the whole meeting.
We want you to keep in touch with us, especially all of us local folks who have a connection with Sibley and Hopkins. So
Will do.
We'll
Oh,
keep us informed, and we're certainly, once you get more numbers and results of scans, I think we can certainly discuss the realistic options.
Herb, I think
Yes.
Bill Franklin wanted to say something, and he doesn't often say something, so can we give him the floor for a moment?
Sure.
I was just going to say, and again, I know we need to move on, but I was going to say, I similar situation. I had a robotic prostatectomy, but my recurrence was almost immediately after surgery, 10 weeks out. But I had radiation and hormone therapy. I was on ADT for 2 years. That was
what is
before.
Okay. Okay. You were on it for 2 years?
2 years, yeah. And
Wow.
that was back in 2015, 2016, and mine has been undetectable since then. So.
Wow, that's wonderful. How long? And that was 2015, 2016. Good.
Oh, that's
Thank
great.
you so much, everybody.
So before we move on, I guess I want to ask the rest of the people who need some time. For example, Dennis McGuire, how are you doing? How is it going with the trial?
Hey, Herb.
Yes.
I'll give an
time
update.
tonight. Okay.
Yeah.
Dennis, let's see. Jerry Palfrey, would you like some time tonight?
Just a short, kind of to bring you up to date.
Okay, great. Les, would you like some time tonight?
Was that me?
Yes.
Yeah, it wouldn't hurt if you had a few minutes. I just want to touch base on my activity with Alicia Morgan today.
All right. And Stan Friedman, would you like some time tonight?
No, not necessary. Thank you.
Okay. Now, I have several names here which are new to me, but maybe I'm also new enough. Alan Dribble. Mr. Dribble? Are you with us? Alan, were you here? I guess he's not. I don't know. Okay. Ron Goldberg, is this your first time with us, or am I?
Alan Dibble. Dibble. D-I-B-B-L-E.
Dibble. Oh, Alan Dibble, are you with us? Is this your first time with us?
Yeah, we're here.
Is this your first time with us?
Yes.
Okay. And Jim Campbell, is this your first time with us?
Yes.
Okay. And also, I have John Haley. Is this your first time with us?
Herb, yes, it is my first time, but I can wait.
You can wait, because that would make life easier, because our usual rule is we really don't have time for more than 3. And Ron Goldberg, is this your first time with us?
No, it's my second time.
Okay, would you like some time tonight?
Yeah. Unfortunately, I have an obligation.
Okay, great.
So it may not work. Ladies and gentlemen, please, if you're not going to be speaking, please mute your microphone.
Yeah.
We're getting some static and some feedback.
Right.
Thank you.
So I'm going to mute a few people here, if you don't mind, before we move on. But now, I think the first person here was Mr. Campbell. You were here first, so let's hear from you. And I guess, given that you've heard the series of questions, I'll go through the same questions. But tell us, how old are you?
74.
74, and where do you live?
Brandon, Florida.
Okay. And when were you first diagnosed?
September 2019.
Okay. That's just like me. And what was your Gleason score?
I'm not too sure. I don't remember that. I got to look up my paperwork. Hearing from you guys, I'm going to get all my paper notes together with them for the next time.
Okay, so you think you can join us on next Tuesday when we
Yes.
can go over this?
Yeah,
Okay,
I'll have it.
and then we're going to ask you these same questions so you know what the routine will be.
Yes.
Okay,
But
well,
I can
great.
tell you
We'll
my
see you.
PSA was 12.
Your PSA was 12. All right,
Yes.
well then let's move a little. We can still move along. So in September 2019, your PSA was 12, and what you don't know your Gleason score, and where were you being treated?
Moffitt Cancer Center in Florida. Moffitt.
And right, and did they do any scans after they found this Gleason score of 12?
No, that was my
Your PSA of 12?
That was a PSA.
Right. Did they do any scans?
Yes, they did.
And
then
what were they? What
they
were
did
the results?
They were just doing a confirmation to make sure I had prostate cancer, a second opinion, and that was it. Then they started treating me in January. We did a brachytherapy. Brachytherapy? That's familiar, right? Brachytherapy. They installed 2 seeds in me. And then they give me lupium, that hormone shot every 2 months. And then
every
I got
3 months.
Radiation for 25 days in a row, except weekends. And the PSA went down to 0.3. And
it went down to 0.3.
Yes. After the third visit, it went back up to 4. So they transferred me to another department now where they do a different treatment. Where I'll tell you the name in a minute.
So
Provenge. You heard about that? Provenge? They take my white blood cell out and send it away and get a remanufactured.
So so this Provenge is immunotherapy.
Yes, that's what I just finished that 2 weeks ago.
Okay.
Right now, I got another one of those Lupula shots, and I'm just waiting to go back in a month time for him to start checking the blood of the PSA to see how it worked out. I'm in a month. Go ahead.
So at least some people have told me, and maybe Len, you can help me here, that Provenge doesn't have such a great effect on PSA.
Yeah, you won't notice much of a change in your PSA, Jimmy, but they have found that people who get Provenge tend to, it tends to, in your case, you got it when your PSA was fairly low, and those people tend to get like an extra 2 years of overall survival compared to other treatments. Now, I think, Jimmy, are you African American?
Yes, I'm from Jamaica.
Yeah, Jamaica. Okay, and so for reasons unknown, African Americans, Jamaicans, they do much better than Caucasians on Provenge. So it was a good choice for you. That's probably why they gave it to you.
I think so. Yes, maybe that's why.
Yeah.
So far, it sounds like you're on the right track. So do you have any questions for us that we can help you with?
I just wanted to know if anyone else had got that treatment. I've got an idea how good it is, how good it works, I'm just here standing by, waiting for the result after I'm going back on the 17th of May, first visit after the treatment.
Right.
Jimmy, a lot of
like you said, Jimmy, you're not going to see a PSA change from the Provenge.
Yes, the doctor told me that's an extended life treatment.
It is.
Yes.
I mean, all the clinical studies say that this really makes the difference. But the thing is, you won't see it in your PSA. I would assume you would see it in a scan.
Well, after the radiation, doctor couldn't go any further. They gave me a scan. At the time, it's very expensive. I don't know how much it costs. And the prostate moved down into my lower back. the cancer cell moved on to my lower back. And that's when they started to give me that treatment.
So I think one thing here is we don't really have a good handle on where you're at, Jimmy. And I think we've got to get a good handle before we start telling you what our experience has been.
Well, what I'm going to do, I'm going to put all my paperwork out with my notepad and write everything down. So when I get back the next time with you guys, I'll have all the information.
Right. I mean,
the medication, everything.
Yeah, we need to know some things like what your PSA, you mentioned your PSA was 12 when you were diagnosed, but we don't know what it's done since. Now it sounds like your cancer is metastatic, meaning it's gone outside of the prostate. That's going to change what we would say to you. I mean, we need to know what other treatments you're on. The drugs that you're on, is it only Lupron and Provenge, or are you on another type of drug?
Right now, that's all. Right now, that's all.
Okay, so there's a discussion to be had with your doc if they think that the cancer is somewhere else, why you're not on additional drugs. Who's treating you now?
Dr. Lufian, the Chinese doctor, Dr. Lufian, at the Market Center.
Okay, and what sort of doctor is he?
What kind of doctor is he? He deals with prostate cancer, advanced prostate cancer.
Okay, is he a medical oncologist, a radiation oncologist, or a surgeon?
He's not a radiation.
Is he the guy that took out your prostate?
He didn't have his prostate taken out.
No, right. He had brachytherapy. Right.
So what time? We're not quite sure what sort of doctor, but you don't think he's a radiation oncologist?
No, the radiation.
Which Moffitt Center is this, Jimmy, that you're at?
The center?
Yeah, is the one in Tampa, or is it somewhere else?
The one in Tampa, Moffitt in Tampa.
Okay, it's Moffitt in Tampa. So, you know, I'm very puzzled by what you're telling me, because we would expect that you had we'd be getting more treatment than just Lupron, especially if they've seen metastasis in your lower spine. So there are some things that, to me, personally don't quite add up. We can ask the other guys what they think, but maybe when you come back on Tuesday, tell us what your threesome was. Len, have you talked to Jimmy before?
Yeah, Jimmy and I spoke about a week ago. Jimmy, I thought you told me that they gave you some pills to take, which are probably some type of hormone pills, like is it bicalutamide, or you recall the name of the pills?
I think it's calutamide. I take it two prescriptions, 30 days each, and they were finished already.
Okay, but Jimmy, that's why I said to you, what else are you taking?
So, the one finished, right? I'm taking nothing.
Okay, but so in other words, you took those pills just for a short time when you before you started the Lupron, right?
No, the Lupron started from January 1st last year. Every 2 months.
And when did you take those pills?
Just before and during the treatment, the Provenge treatment.
Okay, so these pills that you've been taking more recently, not when you started the Lupron.
No, recently, yes.
Okay, and do you know what pills they are?
I'm trying to find the name. I threw the bottle away,
Jimmy, let me just say something to you, which is very important for everybody on this call. It's really, really important to keep good notes about your treatment. You have to keep track in a notebook or somewhere.
Yes.
Okay, you've got to, because otherwise it's hard to track what's been going on in the past, and it's hard to determine what is the next best thing to do. And
okay, the name of the pill I was taking.
Going on.
It's called clorimazole. CLOTRIMAZL.
Right, clotrimazole, which is an antibiotic.
Yes. They gave me that for 2 months. Two 30-day prescription.
Okay, well,
That was just before I started the treatment for the primotive until about it's finished. Then we stop. Don't take it anymore. I'm just standing by now.
Okay, so that has to be with something else that's going on. Have you had a urinary tract infection or anything like that?
No.
No. So, because I don't think that has anything to do with the Provenge. I've never heard of an antibiotic being given before you start Provenge.
It's called clorimazole E-betmet. Betmet. Yep.
Jimmy, is there any chance you could send me your medical records, whatever you have?
Sure.
So look, I think the best bet is we talk about this next Tuesday when we have.
I'll have everything ready.
Yeah.
Okay. Why don't we do this? Why don't we let Len and Jimmy communicate, and maybe Len can get to the bottom of what's going on, and we can go from there, huh?
Yeah. Yes, I think that's better. I'll start getting everything ready for you next week.
Okay.
All right.
Okay. So that's great. Okay, we will definitely see you next week.
Definitely,
so
yes.
Now I think we will. We want to go through the list now. And I think somebody may. I would ask Rick. Would you respond to the dribbles?
Yeah.
The chat window?
No, what I think we should do with the Dibbles is Dibble.
Dibble.
Dibble. D-I-B-B-L-E.
Dibble. Right.
But
sorry.
Now, what I suggest we do is, Mrs. Dibble, would you like to just tell us, rather than going through the history, which you put in the box, and we can take down from there, what is concerning you right now? How can this group help you? The one thing I would like to suggest to you is to join our Caregivers group tomorrow night, which is just for caregivers. You'll probably find it very, very helpful. You join it just like you join this site right now at the same time, whatever time, 8 o'clock Eastern or whatever time it was. But please come into the Caregivers group tomorrow. And if you're willing to speak, I'm glad you've registered. Thank you. If you're willing to speak, tell us how this group can help you and what we can talk to you about with respect to your husband's situation. We have many men who are in the same situation, even on this call, who have had chemotherapy or on chemotherapy, have been on chemotherapy following radiation and treatment. So we're happy to talk to you about whatever you would like us to talk to you about.
Thank you very much. Basically, our concern, mine mostly, he doesn't admit it, but he has the depression and anxiety causes a lot of anger in him. And I understand that this is a situation, because I'm not a man, I don't know what is going through, but I see the end result of it. So we are in this thing that he's angry and upset and depressed, and I want to get him out of that, and I don't know how. He's a veteran. Thankfully, he's got all the treatments at the VA. So financially, we're not stressed, but it's just an emotional situation for him. That,
right. And where do you live?
Like, why me? Why me stuff? Why me?
Right. Where do you live?
In Newport Richey, Florida.
Okay. So I think
he's being treated at James Haley.
He's being treated where?
At the James Haley Veterans.
James Haley. Okay. So I think, we can reasonably throw this out to this group because there are veterans in this group, there are non-veterans in this group, but there are many people who themselves have experienced the anger and are familiar with that anger, and maybe they have some thoughts on how you deal with that anger. And frankly, there are men on this call who are suffering from depression. And I think it's not amiss. We don't talk about it enough on this call. We tend to talk about it on the Speaking Freely call. But I think there's absolutely nothing wrong to talk about it on this call either. Is anybody want to speak up and talk about how they've handled the anger and the depression from being diagnosed?
Yeah, I'll speak up.
Thank you, Bill.
Alan, I was 51 when I was diagnosed. I'm also a veteran, and as I said earlier, I went through prolonged treatment. Originally prostatectomy, then radiation, then hormone therapy for a couple of years, and I believe my depression was attached to the hormone therapy, as well as just the whole going through the treatment itself of trying to fight the cancer. I would highly recommend seeking mental health counseling. It's what I did. I went to a therapist versus any psychologist or psychiatrist, but and that helped me quite a bit. I never took any medication. It was all mostly talk therapy and working through your emotions and how you felt about the diagnosis and what you were doing to deal with the disease. That's what I did, and it helped me a lot. I think that I got better also by getting off of the ADT, because I think that was a big part of my depression. I don't see in the post that your wife put here that you were on ADT, but you may be, I don't know.
Yes, he is on ADT. I didn't know you can get off it.
Well, I went off it because that was the course of treatment. From what you put here, he has his cancer has spread to his hips and his femur. So I don't believe, and someone correct me if I'm wrong, but I don't believe a doctor would recommend getting off of hormone therapy when you have cancer already spread to your bones. So,
I mean, I would say this on that score, that there are some men like Bill and myself who do hormone therapy up front in the hope that we can nail the disease. We're not going to cure it, but we can put it into a durable remission. And some of us have been fortunate enough to do that. And those of us who do probably don't have to go back on hormone therapy. When the disease recurs, and even sometimes for those where they're diagnosed with advanced disease, they don't get off hormone therapy. Some men can take it intermittently. So if, for example, the chemotherapy worked and you drove Alan's PSA down to 0 and it stayed down at 0 for a year or 18 months, you could have a discussion with your doc as to whether he could come off ADT for a while, but then he may have to go back on it. So there are possibilities to get off, but the getting off is only temporary, and we have gentlemen on this call who have gone on and gone off again. So there's a possibility to go on and to go off. The problem that you're faced with is that when you're on the hormone therapy, it exacerbates certain emotional responses because you don't have testosterone in your body. Without the testosterone in your body, the receptors in your brain aren't being serviced properly. And you need some sort of treatment for that. And whether that treatment is talk therapy, whether it is medicine, because there are some very good medicines. I am sure that at the VA, I'm not a veteran, but there are veterans on this call, and I'm sure that there is therapy available to you through the VA. And I would be availing myself of that if I needed it. It's really important because you can feel a heck of a lot better. Is there anybody on the call who, as a result of hormone therapy, has started taking medicines and feels better for taking those medicines? Anybody want to speak up on taking medicines after they started hormone therapy?
Rick, this is Jerry.
Thanks, Jerry.
I started hormone. Well, first of all, just so he knows, I'm a Gleason 9, 4+5, with bone mats up my spine and across my shoulders, and on ADT, hormone therapy, and it was probably close to the end of the treatment. I got diagnosed January of 2019. So about December of 2019, I started taking a mood adjuster, if you will, called venlafaxine.
Venlafaxine.
And venlafaxine, it's the extended venlafaxine, so I take one in the morning. It's 75 milligrams, but all I do is take one in the morning. And probably about February or January of 2020, I started taking some Xanax for the anxiety and that. And I took that for a whole year, and I'm just now titrating off of it. And the only reason I'm getting off of it is I hate taking pills. And so I'm not saying that I'm not going to go back on it, but I'm going to try without it. So that's my situation.
Thanks. I mean, I personally am very familiar with venlafaxine. I've been taking it for many years, long before I was diagnosed. When I've stopped only because are you with us, Mrs. Dibble, or are you with Alan?
Yes, I'm here. I was just trying to get the name of that Venlaflex.
Okay, but you don't need to
it's a prescription drug.
Okay, you don't need to get it because just because Jerry take it or I take it doesn't mean it's the right drug for Alan.
Right.
What it means is it's a drug that works, and you need to have a discussion with your doctor about getting Alan a drug. I would not go into a doctor and say, I want to take venlafaxine.
Right.
Because you've got to leave it up to the judgment of the doctor, knowing you, and deciding what type of depression medicine or anxiety medicine they think is right. If it doesn't work, I was put on I forget the famous antidepressant, Prozac. I think I was put on Prozac first of all. It was a disaster, and then they moved me to venlafaxine. It was great, and I take more venlafaxine every day than Jerry does, but I'm stable on it. So don't worry about the drug name. Worry about getting Alan into a place where he's willing to talk to somebody about these issues, and then letting the doc decide how to treat him and think about some talk therapy. Anybody want to add anything to that?
I would certainly say that the therapy is number one, with someone who can talk you through these issues. But then number two, I would say
the mood enhancer. They have mood enhancer because sometimes he said that your I'm sorry. Oops. I'm sorry. I'm trying to tell Alan this. So hold on.
Okay, so let me just tell you, Helen, that these calls are recorded, and you'll find the call if you sign up to our blog or you go to our YouTube channel, so you can listen to this again later, and Alan can listen to it in his own time. but it's very difficult for us to talk to you when you're talking to somebody else, or we're happy to talk directly to Alan. But what we can't do is have a three-way conversation at the same time, all at the same time.
I'm sorry, that was my accident. I meant to mute. I forgot. I'm sorry.
Okay.
Well, I mean, I think there are at least two parts to this therapy. And one is definitely a therapist who can talk you through these issues, who's trained in these areas, will help. And number two, there's no question that depending on the kinds of moods he's having and reactions he's having, there are different drugs that are available. And for those, you need to see a physician. You can't just go into a pharmacy and say, this is what I want because I'm depressed. A physician will look at the entire situation as a whole and decide what's the most appropriate therapy, just like for the other diseases. So I think that they are very helpful. These drugs work. And I think there's no question that in your situation, they deserve the chance. So are there anybody else who's, I mean, I suppose I could bring up other drugs, but I'm not sure if somebody in the VA system would use them. So
again, I don't think that we are the source to name the drug. We may know how to name a drug when it comes to prostate cancer, but when it comes to handling mental illness, mental health, none of us here, I think, have that expertise. So the best thing we can recommend is to talk to certainly you have a gateway doctor at the VA. The gateway doctor at the VA is the person to start with, and to talk to that person, and then let them refer you. And at that point, whether it's talk therapy and or medical therapy, drug therapy, they'll find the right drug for you.
right. I think that's totally correct.
And
Yeah, I just
mental
want to jump
health
in.
counseling
And I think, you know, despite the fact that people are putting drug names in the chat window, I would think that's at this point, it's not really, I don't think we can decide. I don't think we can even make a recommendation.
Let me just say one thing there. I'm actually part of a depression support group, and no one in a support group would never ever know what drug someone should be on for depression. And in fact, like Rick said about his trying Prozac first, then another drug, it's often you have to try one or two drugs or even more before you find the one that fits you with your doctor. So definitely rely on your doctor for any sort of psych meds, because they don't work the same in every person, and research still isn't there to know why.
I think John is 100% right. The other thing is we cannot give medical advice in this group.
Right.
Now, the only time medical advice gets given here is if we happen to have a medical professional who has expertise in that field, and they also happen to be a peer, and from time to time that happens. I don't know that there's anybody on the call right now who's a medical professional in this field. If there is, happy for to listen to them. But
so the only thing I will say, and I'm not a medical professional, Rick, as you know, but I used to teach these drugs to doctors.
Sure.
They don't work instantaneously. So if it's not working in a day or two, you don't want to say, oh, this drug is no good, and start complaining.
Absolutely correct.
Once you get the prescription, you got to give them a chance to work. That's a really
which can actually be a couple of weeks from my personal experience.
Absolutely. They don't work. None of these drugs work immediately. It's not like an antibiotic or something that knocks down your PSA. But you got to give them a chance, and you got to get them from a professional.
So I want to respond to Tad. Tad, you know, the fact that you and others have taken all different types of drugs and taken treatments, those have been given to you based on the evaluation, the medical evaluation by your medical professionals. And certainly when it comes to mental health drugs, as John correctly said, and I know from experience, everybody responds differently. So we cannot be saying, all we can say is, Lexapro worked for me, or venlafaxine worked for me, which is one of the things I said. Venlafaxine, Effexor worked very well for me. When I went on hormone therapy and I felt more depressed and I recognized the depression, my doc said double the dose. And I doubled the dose and it worked. But that was for me, only for me.
Right.
So
Rick, I think I'd like to just make a suggestion that, you know, please, to the Dibbles, please go see your physician. I also think that if you would like to, if Alan would like to discuss his situation more in private, we certainly would be willing to do that. If he doesn't want to discuss it in public, there are several of us who would be happy to talk over his situation and perhaps help you along that route rather than in this meeting. But I think I'd really feel like we need to sort of move on in the sense of there are other people waiting their turn.
Can I say one thing, Herb?
Sure.
I'm not a medical professional, but the thing we talk about so much in this group fighting anxiety and depression is exercise, and haven't heard that brought up for the Dibbles. And that's you know, I was high anxiety all day today. I had a chance to go to the gym, got on a treadmill, lifted some weights, and you know, it just works wonders. So, and I think a lot of people would.
Well, that's thank you. That is very
works for.
He does. Alan usually goes biking, but because of the chemo recently, it takes all his energy. He hasn't been able to. Right. But you are right. Exercise is a prime thing that has always helped him. Biking, his biking always helps him. He used to do 50 miles last year, but that is the best thing. But anyway, thank you, gentlemen. I appreciate all your help you've given, and I'm going to be leaving in a little bit. Thank you.
And please come back. We'll be here every week for you.
I will. Thank you.
Okay. So moving on, I guess there are three people who I sort of want to catch up with tonight who joined a little less. Ravi, did you have anything to share with us tonight? I thought Ravi was here, but I think he might be gone. Kang, do you have anything to share?
I am here.
Ravi, you're there. Do you have anything to share with us tonight?
Yes. Hold on just a minute.
Okay.
So in my case.
Not right now. Now let me get Kang. Do you have anything to share with us tonight?
I'm okay, thanks. Thanks.
Okay. And then David Muslin, would you like to say? Would you like some time tonight?
No, thank you, Herb.
Okay. So
we also have two people on the telephone, Herb. That we've not had a
could
chance
you
to
identify yourselves on the telephone so I don't miss you? We have caller 2 or whoever's on the telephone.
One is Peter, and I have not.
Okay. That's Peter is caller 3, and caller 2. Is that you, David? No, you're twice already. So
yeah, it's probably it's an 847 number. It's me, Herb.
Now I already got David. He sent me a private note. But if somebody else on the phone still, number caller 2.
Yeah, caller 2.
You know, Herb, I'm on the phone, but I don't know how I should go on there.
No.
Would you like some time?
No.
I'm James. I will be with you next Tuesday.
Yes.
Right. So.
No, James. No. I forget. Who said they were on the phone? Was that Ken?
James.
James. No. Okay. Fine.
Yeah. We got you, James, and we have Ken. Somebody else on the telephone though.
Okay. Right. There is somebody on the telephone who I'm not sure about. So Ravi, would you
It's
like
Gaoshan Wang.
Oh, it's
Gaoshan.
Oh,
Gaoshan, would you like some time tonight? Gaoshan, would you like some time tonight?
Yeah, I have a couple things to say.
Okay, well, we'll definitely get to
you. You also will probably want to listen to the beginning of this call if you came in late, and our conversation with Vince Wilmot and his wife, because it pertained very much to your situation as well. But definitely, we'll come back to you.
Right. Okay, Ravi, why don't you tell us what's going on?
Yeah, so just to refresh my situation, right? So I have a Gleason 9, and it was seen in eight cores. And last time when I spoke to you all, there was this question about why my oncologist was just doing IMRT, and you all suggested that I check in with him as to why, as to the possibility of doing SBRT. My oncologist is a doctor from Johns Hopkins that the other gentleman referred to. I've forgotten his name now. Greco, yes, that's right. Yeah. So one great thing about Greco is that you can write to him and he explains it everything very clearly. So he said that in my case, my prostate extends so far into the bladder that he does not believe SBRT would be the right choice, even as a boost, as done with IMRT, followed by an SBRT boost. His point was that it extends so much into the bladder that nearly 50% of the prostate is inside the bladder, and he thinks that that's not a good setup for SBRT, even though SBRT provides a lower total dose with the SBRT boost. He thinks the large dose per fraction per treatment could harm the bladder more in the long run. So it seems to be that my the I mean I didn't quite totally understand this business of my prostate extending so much into the bladder, but that's the reason.
Well, I think everybody's anatomy is different, just like everybody's cancer is different. And I think these are the reasons why they use different therapies. So thank you for telling us that.
So do you think the prostate extending into the bladder is a consequence of the cancer, or is it?
No, I think it's probably your anatomy.
I see. Okay, yeah. Thank you.
I just like to say, Ravi, that I'm glad we raised it. I think it was a very valuable and viable thing to raise. I don't suspect that there's a concern at this point that the cancer has contaminated the bladder, because I think that would be something a little bit different. That said, IMRT was always the standard treatment until maybe 4 or 5 years ago. And so there's nothing wrong with the IMRT, and it's delivered in smaller, what they call fractions. And so, I'm sure this guy's very capable, and he'll do an equally good job. I think the reason we suggested SBRT was just to make your life easier. It could be delivered more quickly.
Yeah, thank you.
And you wouldn't have to be schlepping back and forth to your treatment as often.
So I am now on the ADT, and that's going to go on for 2 months until, and only then my radiation is going to begin.
Okay. Thank you. So, okay, Les, would you like to share your information with us?
Well, if there's enough time, it wasn't very significant. I was just going to comment that I had a chat with Dr. Alicia Morgans this afternoon, and I thought it was quite informative. I know she has been mentioned several times on this forum, and I was very much impressed with her.
Mm-hmm. Great.
That's about it. I just wanted to comment.
Okay. Jerry Pelfrey, would you
Can
like
I, can I just ask a quick question?
Yes, sure, of course.
Is it seen in with many people that they do this hormone therapy for 2 months, 2 long months before they start the radiation?
Yes.
Okay.
Yeah, usually they'll want you, they do it for a couple of reasons, Ravi. The first is there is a strong belief that the hormone therapy compromises the cancer cells, and so they're more susceptible to radiation.
Mm-hmm.
And that's one reason they do it. So they usually give you at least between 6 and 8 weeks. I think I've got to go back a long time in my memory. I think I started in November, around November 20th, and I didn't start my radiation until January.
Mm-hmm.
Maybe sometime in January. So that's the first reason. The second reason is because it can shrink the prostate, and so it makes if the prostate's a little smaller, it makes the radiation planning a little better.
I see. Okay, thank
so
you.
those are the reasons. And Herb, I don't want to just roll over Les.
Okay. I didn't mean to roll over. I didn't know that it would be nice to hear more about Alicia Morgans.
Right. So.
And what you liked about her.
Let's hear what Dr. Morgan said to you and how it impacts what you're going to do next and what you think you're going to do next. And I think we have to share with everybody in this forum that, we're all aware that Dr. Morgan's is not going to be at Northwestern for too much longer. In a situation like yours, Les, there's maybe no reason why you couldn't follow her and continue to see her on a remote basis with somebody local, working with somebody local. I know that's not possible for all of her patients who are on this call, or may not be. But I had a long chat with Dr. E on Friday, Dr. Efstathiou, and one of the things she said, because we talked about Dr. Morgan's, was, well, nowadays your patients can follow you virtually.
Yes, but in her new position, is she going to handle individual patients? I understand that she's going to be in charge of a larger group of different cancers. So I didn't know if she was going to have any individual patients any longer.
Well, that's a really good question to ask her. My guess is because she's not just a researcher, she really cares about patients, and she is a really skilled clinician, that I don't think she'd move anywhere that put her in a place where she couldn't see patients, because I think that's a very important part of her practice.
Yes, but if she's going to be taking care of a large group, including many other cancers, I didn't think that she would have time for individual.
Have you asked her, Les?
Not specifically, but she indicated that she was going to be in charge of a large cancer facility and covering many different cancers. So I just assumed from that.
Well, don't assume.
Okay.
My suggestion is ask her, can she treat you virtually with somebody local in, you know, in the western part of Illinois. If you liked her, I would definitely recommend. The worst she can say is no, and then we got to figure out who else we can send you to.
Well, she has given me a few other names of people in this general area, one at the Mayo Clinic and a couple at Minneapolis.
Well, okay, Minneapolis we can certainly help you with, and there are other doctors in Chicago that we can help you with too.
Yeah.
Can you put in the chat who the doctors were in Chicago?
More important, Les, what did she say about the type of treatment you should pursue right now? That's the bottom line.
Okay, she was quite, I was a little bit surprised that she was, you know, went along pretty much with what I had been doing. The only thing that she did recommend is that she thought that I should add to it this second line anti-androgen,
Right.
possibly Xtandi. It was probably the first on her choice. The second thing that she recommended to me was, you know, I told her that I was on this Xgeva, that had gone from Prolia to Xgeva, that they had upped my dosage and so forth. And she was not in favor of that. She indicated that was a extreme overkill and didn't think that I should have gone to that. She didn't think that my situation warranted going to Xgeva.
Sorry, did you say you went from Prolia to Xgeva? Or
Yes.
Xgeva to Prolia?
Prolia to Xgeva. That was several months ago.
Okay.
And she didn't think that was a good idea.
Did she say why?
Why? Yeah.
Just that it was an overkill. She said that there's more side effects, so forth, from the Xgeva, and that she thought that the added dosage was not warranted in my situation.
Huh.
But do you still have bone mets, Les, or are they gone?
Well, I don't know exactly right now. I'm scheduled for going back up to Mayo for C11 choline the middle of May, I think 12th of May. So I might find out more then. Although, you know, going for a scan, my PSA is now 0.1. But like,
yeah, the only this is Ken Anderson, Les. The only thing I would say is, were you taking Xgeva monthly or every 3 months?
how's that again?
Were you taking it monthly as an injection or every 3 months?
Which, the Xgeva?
Yeah.
Yeah, the Xgeva is every 28 days.
Yeah, I would say that's overkill. Paul's position at MD Anderson is every 3 months.
Right.
Yeah, that's how I get it too.
That's how I get it.
Really, from what I had understood, that if you go to Xgeva, it's every 28 days. I didn't know that it could be spread out.
Yeah, I did find when I did it every 28 days, I did get joint pain. So I switched it to every 3 months. And he actually stated that that's how he recommended doing it. But my local medical oncologist, because they bill $2,300 a shot, you know, she was doing it every month.
Yep.
Well, I'm due for another shot, just a few days. My intent was to go ahead with this one and then inquire from there if I should continue with this or go back to Prolia, or like you had indicate, go for every 3 months instead.
Yeah. I mean, I think Prolia and Xgeva are the same drug.
Basically, yes. Yeah.
So, and it's just a matter of how it's delivered and how often you get it. And my sense is that
is twice the dose of Prolia.
Right. Right, but it's the same chemical, and so the question is how you space out the injection so that you eliminate side effects. So I think less. I think I would argue that less is more here. The 3-month injection seems to have fewer side effects.
Yeah. Well, I have not noticed any particular side effects from either the Prolia or Xgeva, but Dr. Morgan seemed to think there was some things that were more severe with that than was necessary.
So I think, at least what I hear from Rick, I never met her, but she seems like a very smart lady.
Yes, I would say so. I mean, she seemed to be right on top of everything.
So I might listen.
Les, how do you think you can best handle? First of all, are you willing to consider a second-line anti-androgen?
Yes. I did inquire of that the last time again. Last time I was up and talking with Dr. Kwan, and he said that he would go with that if my PSA would either rise or not go down with just being on eligard. But my PSA did go down and went down to 0.1. So from that, he didn't seem to recognize or advise going to a second-line antigen. But according to Alicia Morgan, she felt strongly that I should be on it anyway.
So that's really what I was going to say to you. I mean, I think most men in your situation, with your history, would at this point in time be on a second-line anti-androgen.
Yeah. I'm not opposed to that.
Right. So the issue is who's going to prescribe it for you, and we can talk about that again next time. But I think if it were me, I would want to be on a second-line anti-androgen. I think the issue around the Xgeva and the Prolia is somewhat fine-tuning. I would defer to Dr. M that maybe you could do it less often. But if you didn't, it wasn't the worst thing in the world. I think that not taking a second-line anti-androgen would bother me a lot more. And, I think a lot of us would love to see you on a drug like that. So the issue is how you accomplish that.
Yeah. I think she indicated, we had talked about a few different ones, the Zytiga with prednisone or Xtandi and others, but she felt that it would be better to go to the Xtandi so that I could stay clear of the prednisone. We didn't get into the reasons for that, but that's what she indicated.
Okay.
I think here again, I think she has some good advice.
Yeah, I think so. She seems to be a smart lady.
Right.
Great.
So
great. And I cannot believe she won't be seeing GU patients. I just cannot.
It would be a shame, to lose.
Right. No, it would be very unusual. It would be very unusual. She'd want to keep up some set of skills.
Yeah.
And
the big issue for you. The big issue for you, Les, is you have to have somebody that can prescribe these drugs. And even if you saw her virtually, I don't know that she could prescribe the drugs for you out of Massachusetts. So you're going to have to, even with Mayo, I don't know how Mayo gets around prescribing drugs for you out of state. They may have a way to do it. So if you're going to go on a second-line anti-androgen, you probably need somebody to toe the line locally, as well as having a quarterback somewhere.
Well, I do see a different urologist locally to get the eligard and also the Xgeva. So I wouldn't think it would be any different to just adding this other Xtandi to the list.
No, probably not. I mean, you know, your urologist cannot give you chemotherapy, but they can prescribe pills.
Yeah. As far as what with Alicia, today we did discuss briefly chemo, and she did not recommend it for me. She said that's not warranted for your situation.
Right. Okay. Well, listen, I'm first of all, good on you for seeking out the second opinion from her. And we are all delighted that you did. And we will help you find another navigator if she's not available to you, if you want one.
And I appreciate you putting me in contact with her. I'm sure that helped. I used your name a few times.
Uh-oh. Okay.
Okay.
All right,
Jerry,
thank you.
Jerry, would you like, you can unmute and.
You talking to me?
Yes, sir.
Okay, real quick. Last week I went for my second eligard shot, and I haven't gotten the labs back, but I know the PSA is less than 0.1 because I've done my PSA here and it's 0.04. But it'll be verified when I get the report from Quest Labs. Other than that, I had an EKG, which is normal, and I had an echocardiogram, which Dr. Rafieth said was better. The outcome was better than what his outcome is. So that's a quick roundup of what's going on with me. That's it. I'm fine.
Great. Thank you.
Well, for those of you who don't know, Jerry came to us 2 years ago with a PSA of 3,000. So some of you might want to take heart from that. At least some of the more recent guys who don't know Jerry. And Jerry, we love it when you come back and tell us that everything's undetectable and you're doing great.
Thank you.
Okay, Carl.
Hello. Okay, moving right along. I have one question concerning Keytruda. I have been informed about directly and also doing some research that Keytruda was not in my future because of my genetic makeup, which includes MSS and low tumor burden. But Dr. Tagawa says, well, that's if you were to take it on its own. If you take it in combination with another drug, it's a whole different story. So that's my question.
He's right.
That's the question.
He's right. And what I would say is, you got to listen in to Dr. Fong at the end of the month, and you got to listen carefully how cold tumors get turned into hot tumors. And one of the ways that cold tumors get turned into hot tumors is by taking them in conjunction with another drug. And we just saw an example of this morning when a drug was, a piece came out using, hold on a minute, because I'm gonna have to pull it up because I don't remember the names offhand. Maybe Len or Herb do, but they gave.
Was it Vayanda?
No, X something.
Oh,
It was,
yeah. Edronixel.
Yeah.
Yeah.
Hold on a minute. I bookmarked it because I knew that my memory wouldn't serve me well and it might come up tonight. So just bear with me 1 second. Immunotherapy, bear with me. We'll put the link in the chat window. It was sent to me by Jim Ward and one other person, and I forwarded it on to Herb and Len and Ken. So the EZH2, it's what's called an EZH2 blocker. Here is the link in the chat window. This is hot off the press news, by the way, guys, and why you should listen into this group. So you can now know as much as I do by reading this article. The drug is called Tazverik, Tazverik, and I'll put that in here too. Tazverik. And Tazverik is a EZH2 inhibitor, and the results showed that when this was used in conjunction with an anti-PD-1, they did not say which anti-PD-1, but Keytruda is an anti-PD-1. It made the anti-PD-1 much more effective. Now, the reason for that, I will not allow, forgive me for saying that, I will encourage Dr. Geller or Len Sierra to explain to you how a cold tumor can be turned into a hot tumor.
I think the answer is attend the webinar with Larry Fong on the 29th, and you're going to learn everything you need to know, much more than Len and I could explain it to you.
Yeah, and Jake, and our man Jake will, if you don't have it, he'll put the registration in for that webinar on the 29th. If you watch the chat window, we'll put it in there for you. So does that help you at all, Carl?
Oh yes, thank you.
Okay.
Right.
Now you have something else going on, which is this BRCA mutation. And one thing that I've seen very, very little of is how mutations like BRCA are impacted, or how they interact with immunotherapy drugs. I just don't know. Has any Herb or Len or anyone else, have you seen anything?
I don't think there's enough experience.
Okay.
Okay, Carl, so that was the answer. So next, Frank, would you like to give us an update?
Sure. I'm up this week on my 6th chemo treatment, Thursday. I'm just finishing up the 5th cycle, and hasn't been an easy one. And I expect that the 6th one is going to be difficult, from all indications and from others who have gone through it. My readings on the last treatment, my PSA in a 3-month period of time has gone from 0.37 to 0.27 to 0.16. So it continues to decline. Before I get this 6 treatment, the doc has ordered up also the latest testosterone reading, which the last time it was 15. So we'll see where it's at this time. My other 2 important readings, my white blood cell count continues to go down on the anemic side. And I've gone from 2 months ago from 12.36 to the last time it was 9.64. And my hemoglobin has gone from 11.8 to 10.9. But to my doctor, he said it's not a surprise from the chemo, and he will continue the treatment for the 6th one. And I am just finished up with my first month on Relugolix, and that replaced my hormone treatment on Firmagon. And I've noticed no major differences taking the daily pill versus the 28-day injection, except I don't have to go through the painful side of the injection.
So Frank, was your testosterone the same or lower with Relugolix?
I haven't seen it yet with it. This will be the first time that I'll see the measurement on Relugolix.
Okay. Any comments for Frank? Any feedback for Frank?
Frank, how are you doing with the metallic taste?
It's still a big problem. It's probably the worst of the side effects from the chemo has been the effects on my taste, the metallic taste, that affects both the roof of my mouth and my tongue. I found as I go through the 21-day cycle of chemo, it tends to ease up the last week and is not as bad as the first 2 weeks. So it gives me hope when I'm done with the 6th treatment that it'll return in a couple weeks,
right?
And it'll go away. My doc did tell me that my next steps after the 6th treatment will be a CT scan to check the nodules in the lungs to see what's impacted those, and also a bone scan to see where everything's at, and then we'll decide what the next steps are going to be in the treatment.
Okay. Well, it sounds like things are working. I mean, how about are you tired? Do you find that you're again in a cycle of you get really tired after a few days after the infusion?
Yes, and again, with each one of the chemo treatments, I find that I started off at 3 or 4 days before I felt that weariness, but this last treatment, I felt it the day after I had the infusion. So I'm expecting that the 6th one is going to hit pretty hard, but that's okay. I've gotten through the others, and I'll get through this one. All I want to do is finish up the 6 treatments and then see where the doc recommends the follow-up treatment.
Well, I say God bless you, Frank. You've done a heck of a job getting yourself through this. And just bear in mind, you might not need it right now when you talk of scans, and your scan is probably too low, but you can get free PSMA scans at in West Los Angeles right now. It's open to all vets. And so if and when, we hope you don't need it, but if and when you need scanning, keep in mind that there's this trial is going on at the West LA Vet Center in conjunction with UCLA, making PSMA scanning available to any vet at any stage.
Yes, I read that, and I was very pleased to see that that's a option that is available.
Right. Okay.
And I also feel sorry for those who are going through the mental depression, because I know even though it hasn't affected me, I've been able to maintain a positiveness through this all, and by focusing on the endpoint instead of what's going on with each treatment. And I know a lot of them, those suffering can't do that. And especially the veterans, knowing what they've gone through, it really hits hard to see that going on.
Yeah.
Well, thank you. Keep up the good stuff, Frank.
Yeah, I'll check in the next one after my 6th treatment, and you'll probably hear a cheer going on in Columbus on Thursday.
Believe me, when that metallic taste went away and wine tasted like wine again, that was a great moment.
Yeah, I'm looking forward to pasta tasting like pasta.
Yeah, Herb wanted his wife's matzo balls to taste good again. That was his issue.
Right. Okay. Dennis McGuire, how are things going?
Hey, thanks, Herb. Good. Hi, everyone. Yeah, I've got a PSA update. So I am getting a PSA response from the lutetium trial. When I started the trial 6 weeks ago, my PSA was at 98. And Friday, my PSA came in at 51.
Hey.
It's great, Dennis.
So that's after one treatment. I had the second treatment on Friday. And next step is in 6 weeks, I'll do scans. So we'll do CT, bone scan, and another PSMA PET scan. And then do the third treatment. So
that's good news. Congratulations.
That's fantastic, because really you're our first lutetium patient, and it's really good to see those numbers.
Yeah, I still got a long way to go, but it's encouraging.
Hey,
trending the right way.
Right. Do you have any side effects? Have you been feeling any other side effects?
You know, this the second injection, I'm feeling better. So I would say fewer side effects. I think some of it was the first treatment, I had to stay in the hospital for 3 nights, which is, you know, I think that saps your energy. So yeah, I'm feeling a little better.
That was just part of the protocol, though, Dennis?
Yeah, that was the protocol with this one, is they wanted to monitor the radiation and how the uptake was.
Dennis, can I just check? So back in February, you said your PSA was 96 before the first treatment?
March 3rd, it was 98.
98 in March.
Yeah.
And now it's gone down to 51, did you say?
That's right.
This
Wow.
is great. This is great. You know, we have had other lutetium people. I think the problem has always been, we've had a number. The problem has always been, with the exception of one person I can think of, who really didn't have advanced disease. The guys that we've known that have gotten the lutetium treatments have always gotten it very, very late in the disease cycle. And we always thought, look, if you can get this in, and they've had a response, but it hasn't been durable. And so getting the lutetium much earlier in the disease cycle when you're much healthier, because they weren't healthy when they got it. This is true. This has been true both in the United States and in Australia, where we've known people. It hasn't worked, but maybe, and we know the trials say it works. So, you know, what we've sort of felt is get it into these guys when they're healthy. And so I think you are the first person, Len, wouldn't that be right? The first person we can think of who's gotten it when they're in a much healthier state.
Yeah, to my knowledge, that's true. And this is what the oncologists have suspected all along, that if we could only introduce this therapy earlier on, it could do a better job. And looks like that's playing out for Dennis now. That's wonderful.
We're so happy for you, Dennis.
Dennis, keep us informed. We're hanging on every word here because this is major.
Hey, Dennis?
I appreciate it.
Dennis?
Yeah, I hear you.
I was distracted, and as far as I could gather, just the last few seconds, from one lutetium treatment, your PSA was halved from 100 or so.
Pretty close. Yeah, so it's encouraging.
Dude, that's amazing.
I think it's fantastic.
Really, really, really is. Yeah.
Okay, David, we're all with you. Dennis will lead you on this one. So we'll be interested in the next numbers. So Gao-Shan, how are things? Are you there? Gao-Shan?
Come in,
there.
Gao-Shan.
Come in, Gao-Shan. Okay. I think we'll come back to Gao-Shan. Don?
I think we named him incorrectly. I think I had Alan Dibble and Gao-Shan mixed up. I think Gao-Shan dropped off and Alan is still here.
Oh, okay.
I don't know what happened.
That's all right. Don, would you like to fill us in?
Sure. I've haven't been here in about a year, and there's really not a whole lot to report. But so coming up, May 6th will be the 7th anniversary of my prostatectomy. Going in, I had a PSA of 20. I was 4+3 T3B, so had seminal vesicle invasion and a margin. And so a few months later, did adjuvant radiation therapy, 18 months of Firmagon plus Zytiga, and have been since then, depending upon which facility I use, either less than 0.01 or another facility between 0.02 and 0.06. So I've just been bumping along. Recently, about 9 months or a year ago, I started actually some my testosterone never really came back. So after the Firmagon, really hardly it became detectable, but just barely detectable. So about a year ago, I started some testosterone therapy. So I actually have that back up to kind of a middle range. Feel good because of that. That's it.
Okay. That's great.
I want to talk.
Any comments here?
Come on, Jimmy.
Don, you're like my twin brother, pathology-wise. It's a pleasure to see you doing so well. It gives me great hope for myself.
Good.
How long were you on the Firmagon?
18 months.
18 months, and it never came back. And when did you decide that you were going to sort of give up on it and supplement?
Well, when you say give up on it, I mean,
give up on it coming back. You know.
Oh, well, it was 3 years maybe.
Oh yeah.
And yeah, so about 3 years. I mean, it was pretty steady at just bumping along at almost nothing for about 3 years. And you know, just I was concerned that, you know, there, as everybody knows, there are downsides to not having testosterone bones. In fact, I got, you know, I've got osteopenia, which was probably due to both the lack of testosterone plus I was taking Fosamax maybe, and we stopped that as soon as I stopped the Firmagon, which was obviously a mistake since the testosterone never came back. So anyway, just trying to get bone health better, and also there's some dementia-related issues possibly from not having the testosterone. So things like that.
Now being. Okay.
And the you know, the one of the people that I see is Schultz, Dr. Schultz in Marina Del Rey, and he would say that if you have a little bit of testosterone, and I forget the exact number, but if you have that, you know, there's a saturation model of testosterone and cancer, which says that it doesn't take much, and the receptors are saturated anyway. So whether you've got a little bit or a lot, you know, as long as you got a little bit, then, you know, it doesn't, the cancer doesn't care.
Well, I've got 23, and it is surging through my veins.
Yeah.
I'm hoping for a little bit more.
Yeah, yeah, I understand. And our hairline's the same.
Beautiful, isn't it?
Yeah, but yeah, I bet you don't play the guitar quite as well as Jimmy.
No, but I play the clarinet.
Oh, you guys could be perfect. Jimmy,
Right.
maybe we'll get Don to perform with you at the end of May.
Former group, we'll call it the T3Bs.
Okay. So, thank you. So, Jake, you had something to tell us.
Yeah, thank you, Herb. If you listened last week, I've been trying to get an oral chemotherapy drug called cyclophosphamide that you take with a low-dose steroid. And my doctor ordered it today, so hopefully once it gets through the specialty pharmacy and gets the approvals from my insurance, I'll be having, hopefully I'll get it within the next week. That's all I had.
Well, I mean, how you got it is a good story in itself, right?
Yeah, it is. And I want to thank all of you guys, especially Joel Blanchette, for hooking me up with Dr. Antonarakis in the first place. I don't know if Joel's still here. But yeah, thank you very much. We'll see if it works. It does have some side effects. It's not as innocuous as I first thought.
It's got some hematologic side effects. So and she's got to watch out for that.
Yeah, they say 50% of the people have vomiting, so that should be fun.
Jake, is that considered an off-label drug now for you?
You know, that's a good question. I don't know for sure. I don't think it's FDA approved specifically for prostate cancer, but they have done some trials, and it is commonly available, and she was able to get it off label. Even if it is off label, she was able to get it. I assume, assuming the insurance company doesn't bulk for some reason.
All right, thanks.
Jake, I have a couple of questions. One is a suggestion. The first is, and I always forget the name, but Len will remember. There's a very good antiemetic that a lot of the guys swear by,
Yeah, Zofran.
Zofran, thank you. And
Well,
so
I actually do have one. She gave me, it's not good though. It's not that one, but it's something else. Granacitron, I think.
Yeah, same class of drug. Yeah.
Yeah.
okay.
So I do have that I'll take if I need it. Thank you,
So
Rick.
take it and hopefully it works. If it doesn't work, make a note of Zofran because that might work for you too as an alternative. Okay.
How's that spelled?
Zofran.
Okay. Thanks.
Okay.
We'll do.
Secondly,
what was the name of that drug?
Which one? The one that Jake has, or the one that we recommended as a backup?
No, the one that Jake has.
I think it's called
cyclophosphamide.
Yeah, it's a long name. Granacitron is what I want to say. I don't have the package in front of me, or I'd tell you specifically, but I think it's Granacitron.
Gary, are you asking about the antiemetic, or are you asking about the chemotherapy Jake's going to do?
The chemotherapy drug.
Okay, it's cyclophosphamide. Somebody will put it in the. It's in the chat window.
I already put it in there.
Thank you.
Chat window. Okay.
Mm-hmm.
Jake, the other question I had is, was it easy to get it through Dr. M?
Yeah, they didn't give me any trouble. I don't think she'd ever heard of it for prostate cancer. So I did send her some links, and so the next thing I knew, they were ordering it. So no problem.
Good.
Fantastic.
Yep.
Fantastic.
So, well, Jake, once you get it, we'll be expecting lots of positive news.
Okay.
Yeah.
I may log on with a bucket in front of me, but we'll see.
Right, we'll see. Right.
Jake, if you're not going to lay across your red mermaid style or turn your camera off, I'm going to have to move my webcam over to my bed and do that to continue to help represent the brand.
I didn't catch that, Jimmy.
I said, if you're not on camera or if you're busy throwing up, I'm going to have to move my webcam to my bed and lay across it mermaid style so that I can continue to represent the Hannam brand. I'm willing to do that for you.
I do that. It's some people might think it's rude, but it's the only way that I'm comfortable laying on my side. So that's why I do that.
Regardless.
Got to do what works.
Yeah.
Right.
Thank you, Herb.
Great. You're very welcome. Dennis, Korea.
Yes, just to update everyone on, after we talked last week, I had just gotten the news that my PSA is on the rise after my 8-month intermittent therapy. I mentioned it had gone up from a 0.1 to 0.9. So a 9-fold increase, even though it's a small number. And I did have my meeting with Dr. Rafia here in Tucson. And when he came in, he says he just got off the phone with Dr. Singh and that he had to call Dr. Singh at his home because that was his day off. So they discussed my situation, and the bottom line is that I'm going to retest again in a month for the PSA, just for the PSA, and they would like to see it rise to 2 before a PSMA scan. And the other good news I got is that the Mayo in Phoenix is expecting approval for the gallium-68 PSMA within a month's time. So if everything works out the way I'm thinking it's going to be, my PSA will probably rise to 2 or very close to it by that time if it continues at the rate that it rose over the last month, which was basically a 24-day doubling rate. And then after the PSMA, then we'll discuss the potential options are. Depends if everything, if all of the mets and so forth are hot again, and we may go back on to the same drugs that I was on before with the Lupron and the abiraterone and prednisone. But if it's just a limited one someplace, maybe a new one or who knows what, radiation might be an option. So, but I'm just going to wait till then and just see what the PSA does in the meantime here, and if we get to PSA 2 fairly quickly, and then get in for the scan.
Any discussion on further chemo, Dennis?
No.
You responded very well to chemo before.
If it, it worked for me pretty well before, took me down, and it lasted for a year before it started rising, and then they added the abiraterone. So I'm sure there are even additional options, but we, really didn't start to discuss, no sense in discussing those until we know what's going on with the PSMA scan. But it's, it's a roller coaster ride, as we've all know about, that the ups and downs of this disease. And so I'm, even though we're heading for a downer right now, I guess, with this, looking to the upside of it and get going again.
Yeah, but Dennis, there is an upside. They'll put you back on those steroids again. And remember, then your golf game will get better once you get back on those steroids.
That's right. Yeah. Although I had a fairly decent one today. Played 8 holes today. Yeah. So with a net 200 bar. So.
I get worried about you driving around in that 917 when you're on those steroids. I'm much happier when you're off the steroids. That car.
Well, it's a 718.
718. Is that what it is? 718. I always get those Porsche numbers wrong. 718. Sorry.
We're scheduled to do a national Porsche Club meet up in Scottsdale in a week or so. Okay. So we'll go there for 4 days and do some driving of the mountain roads and back roads up around that area.
Okay, lay off the steroids beforehand, okay?
Yeah, I'm not sure I want a whole lot more adrenaline right then.
I wish steroids would help my golf game, but it's no use.
So before we'll go, I just want to give my own quick update before we go to Len. So as some of you remember, I was getting spot radiation in my vertebrae. The first treatment actually was today. I had, had a nice 30-minute nap while this machine circled around me, shooting me up with radiation. And I was able to moderate the meeting. So obviously, I'm not feeling too bad. The only interesting thing that happened is that last week when I was getting my pre-exam, they wanted to take a PSA test. And I did not expect that they would do PSA because NIH has been doing it in this radiations at Georgetown. But the guy, my physician said we really would like it for our record, so I exceeded. And then it turns out that the Georgetown number in January was 1.8, and last week was 1.4. So higher than I would like, but in the right direction. And then my wife reminded me that I had done stationary bicycle in the morning quite rigorously. So who even knows what the 1.4 means? So that's where we are right now. And hopefully things will continue in the right direction.
Wow.
So,
you're a scientist.
Then,
Good news, Herb. Glad to hear it's going in the right direction.
Yeah, it's still higher than I would like. I mean,
Yeah,
I'm
sure.
listening to your number, everybody's numbers, and they're much lower than mine. So
Yeah, give it a little more time. It'll continue.
Herb, I'm at 373, so I've got you beat by a long shot.
well, you're right, Jake, but we hope yours comes down pretty quickly with the cyclophosphamide.
Herb, is there a reason you're not supposed to exercise before a PSA test?
Yes, because if you do like stationary bicycle, you're jostling your prostate and it's driving PSA up. So you're not supposed to exercise for 24 hours before a PSA test.
Whoa. You're not supposed to cycle and you're not supposed to have sex. But other exercise.
I thought other vigorous exercises might do it too.
Well, the two things they say are sex and bicycling. That's what I've always heard.
So.
Okay, thank you.
I don't have to worry about the sex, but the bicycling I do.
Herb, you did the bicycling before the PSA test?
Right, I did not expect to have a PSA test. So every day I do 30 minutes of stationary bicycle in the morning.
I was wondering how a scientist could voluntarily do a bunch of stationary bike riding before a PSA test, but now I see. Now I see.
Len, fill us in.
I just want to say, Jimmy, I don't know what happened to your sound. You used to come in nice and clear. You've been very muffled
it's very
tonight.
Muffled. Yes, it's true.
Yeah.
I'm sorry.
Go back to what you were doing. Anyway, Herb, I'd rather punt until next week.
All right. Well,
mine's not worth keeping, guys. Here, let's all say good night. Thank you, Herb.
Okay. Well, good night, everybody.
Good night, everybody.
Thank you. Good night.
Hold on 1 second.
Good job,
can we just check on Gaoshan?
Oh, man.
It wasn't Gaoshan, according to Jake.
Yeah, he's not here, Rick. That was just a mistake.
Okay, that's what I thought that, but I just wanted to check one more time. Okay. All right, guys.
All righty.
Good night.
Thank you very much.
Rick, stay on for a minute.
Let me turn off the recording here. Hang on.
Yeah.